Welcome all participants. I am Rosa Moysés from Brazil, and I would like to thank the European Renal Association for this invitation. I am moderating this e-seminar, which will be presented by Professor Markus Ketteler from Germany, and we'll have two panelists, Dr. Jordi Bover from Spain and Dr. Sandro Mazzaferro from Italy. I would like to remind you that participating live, participants will earn 1 European credit for their continuous medical education. This is an exclusive benefit for European Renal Association members. So this e-seminar is coordinated by the CKD-MBD working group from the European Renal Association. So, Professor Markus, please.
Thank you, Rosa, for your kind introduction. I will now set up my presentation, and I hope that this is visible for all of you. The topic of this today's seminar is the treatment of secondary hyperparathyroidism in non-dialysis CKD. So something that was controversial in the last years because of the KDIGO guideline update and because of some studies that were performed on this issue. First of all, my disclosures of interest. I will let you take a brief look at this. And now I would like to go ahead with the contents of my presentation. Just as an introductory slide, what are we dealing with? We are dealing with a syndrome, CKD-MBD. The term was coined about 15 years ago because the previous term, renal osteodystrophy, covered the bone complications of chronic kidney disease, but it did not cover so much the cardiovascular part, the vascular calcification, and the relationship to mortality of this, these changes that occur with regard to mineral homeostasis. The pathophysiological basis is depicted here on this slide. And on the left slide, you see the more traditional view of how secondary hyperparathyroidism and CKD-MBD functions. Because kidney disease, in a way, leads to disturbances in terms of less activation of active vitamin D, which directly kind of disinhibits PTH release from the parathyroid gland, but also leads to transient or even continuously present hypocalcemia, which centrally stimulates PTH to get secreted. We know from studies that also hyperphosphatemia triggers the parathyroid glands to release PTH, but we thought in the past that this is a relatively late event in the course. On the right side, you see that another hormone is present here, which is FGF23, and this is probably the first hormonal dysregulation that occurs with CKD. And this has obviously the task, together with PTH, to keep the hyperphosphatemia prevented until the late stages of CKD. As a second action, FGF23 directly stops or inhibits hydroxylation and activation of calcitriol. And by this effect, the progression on the left side follows further on and is supported directly by the presence of elevated FGF23 levels. On the gland level, what occurs first is that there is a kind of a polyclonal hyperplasia of the glands, which still is relatively perceptive to treatments, because the calcium sensing receptor and the vitamin D receptor are only modestly downregulated. What it comes to in the course of hyperparathyroidism with regard to the progression is that nodularity and adenoma-like structures occur, and these get less and less susceptible for treatments that we apply to stop it. So this is the goal of what we try to achieve, to prevent progression from the diffuse hyperplasia to the specific monoclonal hyperplasia in order to prevent therapeutic resistance and parathyroidectomy. And this, of course, directly relates to the topic of my lecture, because this transgression occurs relatively early and not just or not as late as in the dialysis stage. With regard to the present guidelines and covering the situation in non-dialysis patients, the first statement is a funny one, because it says that in patients with CKD 3A to 5 not on dialysis, the optimal PTH level is not known. This is true, but of course, this is not very helpful, because we don't have a good clue when to initiate or when to even stop treatment and when to overtreat the patients, because some elevations in PTH is probably something good for coping with changes that occur during progressive CKD. The guidelines were kept from the previous ones in a way, and the secondary reasons for PTH elevations, be it hyperphosphatemia, hypocalcemia, high phosphate intake, vitamin D deficiency, they should be looked at and potentially corrected if they fall out of place. What are the renal effects of PTH? PTH is increasing reabsorption of calcium, and thus recovering, for example, hypocalcemia. It also induces reabsorption of magnesium, and it inhibits reabsorption of phosphate. So PTH together with FGF23 is a strong contributor to diminish or to inhibit and to protect the patient from hyperphosphatemia. And then it stimulates the enzymatic conversion of vitamin D of 25 OHD into active calcitriol. So the calcitriol deficiency, in a way, would be counteracted by PTH. And in addition to these renal effects, PTH also affects the bone. And with patients getting more uremic in the course of their diseases, the bone gets unresponsive or less responsive to the PTH actions on turnover. And so the bone for normal turnover probably needs higher PTH doses. An analysis of the time course of perhaps the three most important scenarios of CKD-MBD shows that indeed already in CKD stage 2, about 30% of the patients may have elevated FGF23 levels. And here this is only 10% of PTH elevation. But the PTH stimulation above the normal range occurs in CKD stage 3A to B in about 1/3 of the patients, in half of the patients in 3B, and in 70 to 80% of the patients in stage 4 or 5. So this is something that is of importance. However, this just means that PTH rises above the normal range. And as I already pointed out, we may need PTH levels that are 2- or even 3-fold elevated to counteract hyperphosphatemia, to get bone metabolism going, and to get the calcium situation supported. And just one look at the tubular side with regard to hyperphosphatemia and phosphaturia. It now became very clear in the last up to about 10 years that both PTH and FGF23 inhibit the two key sodium phosphate cotransporters at the kidney level, NaPi2A and NaPi2C, by distinct intracellular mechanisms. So the body indeed employs two hormonal systems in order to protect us from hyperphosphatemia, which at least to some degree may indicate that this is important to save the body from damage. And looking again in the sequence and in the time course of events, in a way, PTH elevations is the third step in the development of CKD-MBD. First one is the elevation of FGF23. This is directly followed by the inhibition of calcitriol hydroxylation. And when this occurs, PTH levels go up. And phosphate hyperphosphatemia occurs late. So the question is when to tackle the elevated PTH, at what levels and under which circumstances. And this is probably not an easy decision to make. And in this regard, the new guideline update in 2017 contradicted in a way the 2009 version. While 2009 KDIGO guidelines suggested treatment with calcitriol or vitamin D analogs when PTH starts to rise and remains elevated, it is now said that these calcitriol and the active analogs should not be routinely used. It should only be used in the later stages of CKD, so below a GFR of 30, and in patients with severe and progressive hyperparathyroidism. The question is, of course, how to define severe and progressive hyperparathyroidism, and we may possibly come to that in the discussion, because I do not want to offer something as a definition right now and at this time of the lecture. Why was the routine use contradicted? This is based on two studies. One of the studies is the PRIMO study, published in 2012, where 230 CKD patients were enrolled in order to look whether pericalcitol had a beneficial effect on the progression or regression of left ventricular hypertrophy. It was a comparison to placebo, and LVMI was measured by echocardiography and also supported by MRT scans in a one-year study. The basis for this study was that in animal models and in a small pilot trial in dialysis patients, vitamin D showed some biological plausibility to beneficially affect cardiac remodeling. Actually, as a key result of this study, there was no change difference in LVMI between patients on placebo and pericalcitol. Actually, after 6 months, there was a significant advantage in the placebo group, but the episodes of hypercalcemia were more frequent in the pericalcitol group compared with the placebo group. And this was a difference of 23% of patients versus 0% of patients. And here on the graph, you can see what happened. The pericalcitol treatment lowered the PTH into the normal range. And this is probably physiologically regarded an overtreatment in this regard. And as this was not the only study, OPERA study from Hong Kong showed a similar picture, even with a lower pericalcitol dose of 1 microgram per day. There was no difference in the left ventricular mass index endpoint after 1 year. And there was also much higher serum hypercalcemia occurrence in the paricalcitor group. It affected about 40% of the patients and no significant number of patients in the placebo group. Nevertheless, it looks as if early or as SHBT control prior to entering dialysis may be of some significant importance clinically and maybe even economically. This recent paper from this year is a DOPS analysis that looked at a total of 2,800 patients for PTH outcome analysis before and during entering the dialysis stage and watching them for 1 additional year. Here you can see the distribution of different PTH levels in those patients when they became incident dialysis patients. And fortunately, the largest group was in the range of 100 to 300 picograms per ml, most in the 150 to 300 picograms per ml group. But you can see here that levels of above 450 were sometimes present in more than 30% of the patients already, which, or even here, above 40% of the patients. So this indicates some kind of potential therapeutic resistance. And here is what happens with the treatments once these patients start dialysis, depending on their previous PTH counts. You can see that for example, those patients with the highest incidence of or the highest levels of PTH, about 70 to more than 80% had to receive active vitamin D compounds. And at 1 year, above 20% had to receive also calcimimetics. While those patients who were in this yellow range, it occurred that about 50%, so 150 to 300, about 50% were receiving active vitamin D compounds, and less than 10%, less than 5% calcimimetics. So this prior control may facilitate this. Nevertheless, look at the last bar here, for example, even in those patients who started with levels of above 600, about 2/3 were able to be lowered, or 60% were able to be lowered into the ranges of below 450 and 70% below 600. So treatment efficacy is still pretty good, even when dialysis was started under those conditions. Now, what about vitamin D status? KDIGO guidelines were just continuing what the 2009 guidelines were saying. And the general recommendation was that vitamin D deficiency and insufficiency be corrected using treatment strategies recommended for the general population. So what is recommended for the general population? This still in a way goes back to the Institute of Medicine recommendations from 2010, 2011. And based on a large systematic review, this is a PDF of about 80 pages. The recommendation was a serum level for 25 OHD of 20 to 60 nanograms per ml. And they also said that 600 to 4,000 units per day of vitamin D3 are safe and do not lead to overkill or adverse effects on calcium levels, etc. They make a point, however, that the proven benefit of vitamin D is in the context of bone health, and those pleiotropic effects on immune function, on the heart, and everything else is not proven. Research should continue. And given the results of Vital, and DO Health, the overall negative effects on increasing the dosage of vitamin D got not more support for recommendations in this regard. However, populations with relatively intact vitamin D status were included in these randomized controlled trials. In addition to the IOM, especially the Endocrine Society guidelines and the early NKF KDOQI guidelines recommended a higher range of 30 or above 30 nanograms per ml for 25 OHD. And this is more addressing the situation for risk prevention of osteoporosis. And nevertheless, the KDIGO recommendations now in a way suggest at least above 20 or maybe better above 30 nanograms per ml. Whether this is the right recommendation, I will come to in a few minutes. What do we know about the relationships, for example, of 25 OHD levels and active vitamin D? This is just an observational, no interventional trial. But in these patients with non-dialysis CKD, the 25 OHD levels correspond relatively well with calcitriol levels. So the less vitamin D deficiency, the higher the calcitriol availability. And vice versa, the less deficiency, the lower the PTH levels, the more D3 deficiency, vitamin D deficiency, the higher the PTH levels in this observational trial. And from the same study, a distinction about the kind of severely deficient patients versus the less deficient patients. So 25 OHD of here, less than 50 nanograms per ml, was associated with a faster progression towards dialysis and with a higher mortality rate. But as I said, this was not an interventional, a randomized control trial. This was an observational analysis. What we know, for example, however, about the relationship of vitamin D status and PTH levels was published 5 years ago, for example, in this meta-analysis. Studies were cited where the impact of vitamin D supplementation on PTH were studied. And you can see here in the above panel that all of these 4 studies led to more or less significant increases in the 25 OHD levels that were significant and measurable. However, in none of these studies, the PTH was affected, although one can say that the prevention of a rise in PTH, freezing the levels at the baseline, may already be a therapeutic effect, but this is hard to prove. But I just mentioned that possibility for potential discussion. An important point, though, is probably the interdependency of bone biomarkers and the control of the biomarkers. I already mentioned that PTH, calcium phosphate are interrelated. FGF23 is an important player, and vitamin D too. And they relate to surrogate parameters like vascular calcification, bone abnormalities, and parathyroid gland hyperplasia. And this would relate to direct heart and meaningful outcomes for the patients, including cardiovascular disease, fracture risk, and or parathyroidectomy. And of course, especially for the last part, but also for fractures and possibly also for calcification, PTH is involved. And the KDIGO guideline update 2017 especially pointed to the fact that we should all consider phosphate, calcium, PTH as one unit together before we just try to turn the screw on one of these factors and forget that the others are interdependent here. What do we know about PTH and mortality in non-dialysis CKD patients? And here it is indeed, for example, in this trial from the US, suggested that an increase is reflecting a bit of a higher risk in mortality. Here, the hazard ratio is already up in the twice above normal range, but this is not significant. In the 3 times the normal range, it is also a trend, but not significant. Only in this overall population, when the levels are above the 3-fold of the normal range, there this relationship is doubled and gains some statistical significance. For PTH and fractures, it has been shown that fracture rate is, first of all, gender dependent. So women, and this is similar to the normal population, break their bones independent on the CKD stages more frequently than men. When looking at the stages, with any stage there is some degree of an increase in fracture risk. This is the 3-year cumulative incidence. And when the PTH at this time is already very high, above 900 here, versus 150 to 300, this is frequently increased. And patients with fractures, when compared to the group of patients without fractures, on average have higher PTH levels. So that may be an indicator that high turnover bone disease may contribute further to a pre-existing osteoporosis, for example, or just reflect maybe a more aggravated chronic kidney disease. When we now look at the differential vitamin D associated treatment effects, we have a few choices. We can try, like the recommendation for osteoporosis protection prevention, use D3 cholecalciferol, where we get the 25 OHD levels up with. We have no effects in general on calcium and phosphate levels. We have usually no effect on FGF23, and there may be in higher doses some degree of PTH downregulation as well. In some European countries, an immediate release 25 OHD calcifediol is available, which has, at least from the studies that were published here, relatively similar effects like the native D3. All active analogs, including calcitriol, pericalcitol, 1-alpha, and so on, they, by feedback mechanisms, lead to some decrease in 25 OHD levels. They tend to increase calcium and phosphate levels, but they are very potent in order to decrease the PTH levels, and they stimulate the secretion of FGF23 from the bone. And I think most of us would agree that the beneficial constellation could be to get further increases in 25 OHD levels that may have impact on PTH. And one compound that is available at this moment since already a couple or 3 years in the US is ERC, extended release calcifediol, which is preparation of 25 OHD which is very slowly released in the intestinal tract because it is put into some waxy formulation, and it takes a steady long time to reach optimal reabsorption. The absorption steady state is only reached after 3 months. Elimination half-life of ERC is about 11 days in healthy and 25 days in subjects with CKD stage 3 or 4. And it can be administered in 30 or 60 microgram doses. And the availability for this compound will probably be early next year in Europe. The explanation for a differential effect here may be related to the catabolism of vitamin D. In order to protect the body from hypervitaminosis D and hypercalcemia and hyperphosphatemia, the high vitamin D doses that are entering the body or that are actively produced or overproduced by the kidney turn on so-called CYP24A1 hydroxylases, which are catabolic for both 25-OHD and 1,25-dihydroxyvitamin D. And so once levels are reached that are too high, these levels are detoxicated immediately. And these mechanisms, at the same time, the 1-alpha hydroxylation, so the build-up of 125-OHD is also inhibited. When working with the active compounds and working also with too high concentrations with 25-OHD, when they rise up pretty highly, these catabolic and inhibitory anabolic events are further accelerated, leading to a decrease in the available active or pre-active vitamin D prodrugs. And here the ERC, due to its pharmacodynamics and kinetics, is possibly in charge, or it has the possibility that the catabolic 24A hydroxylases are not upregulated by the slow release, and lets permits the 1-alpha hydroxylation of calcitriol on a slow and steady basis, and by that lead to an increased effect on PTH levels. The pivotal trials were 2 parallel phase 3 studies in which patients, a total of more than 400 patients, were started with 30 micrograms of ERC daily, and then with those patients with insignificant efficacy could be titrated up to 60 microgram ERC daily. And from this pivotal trial, over half a year, about 300 patients entered a so-called open label extension study. And the endpoints here were the effects on 25-OHD and on PTH levels. And here you can see the pooled results from both studies on PTH. You can see that there was a significant and steady lowering of PTH levels from about a little bit less than 150 picograms per ml to a little bit more than 110 picograms per ml. In the placebo group, this was continued at the previous level. And when then placebo-treated patients were also getting the open label ERC, and the ERC patients were continued for 1 year, you can see that the PTH lowering in both groups were then sustained pretty much. The effects on calcium and phosphate, and this is of course an important finding, were nearly not recognizable, especially the occurrence of hypophosphatemia and hypercalcemia was not significant versus the placebo control. And when then looking here at the left side of the relationship of quintiles of the reached 25 OHD levels with the reached effect on PTH levels, then you see that the PTH was lowest the higher the vitamin D, the 25 OHD levels were elevated. And the cutoff for a sustained response here were 25 OHD levels of 50 or above nanograms per ml for 25 OHD. Then the effect continued to 80, 90 nanograms per ml. So it may indeed be the case that we should aim for higher 25 OHD levels than we did previously in order to keep a good control on secondary hyperparathyroidism in the pre-dialysis phases. And then the question will be whether this can only be achieved with such a extended release compound, or whether it could potentially be possible to reach it also with a native compound. But previous studies at least left some doubts with the latter assumption. So my last slide. In summary, in CKD stages 3 to 5, the optimal PTH level is not known. As physicians, our aim is not treating elevated PTH serum levels, but their pathobiological consequences, bone and the vessels especially. And we must find a way to find out whether this pathobiology is really happening. In order to judge PTH levels right, we must always consider looking at calcium phosphate and perhaps concerning the bone at bone alkaline phosphatase levels in parallel. In non-dialysis CKD, active vitamin D analogs possess an associated hypercalcemia risk and should only be used in significantly active and progressing SHPT. ERC seems less hypercalcemic and hyperphosphatemic while lowering PTH effectively. Treatment effects may, however, essentially depend on reaching higher 25 OHD serum levels. So potentially we need to aim for 50 to 80 nanograms per ml. And with that, I thank you very much for your kind attention. And I will now stop my sharing my screen and be available for questions and answers.
Thank you, Markus. I will ask the panelists to make their comments. Please, Jordi and Sandro.
Well, I don't see Sandro. Sandro, would you like to go?
You go, Jordi. You go first.
Okay, thank you very much. Well, thank you very much, Markus, for your very nice conference. Actually, you mentioned from the beginning in your summary, that there is a debate when we deal with PTH levels that should we aim to the non-dialysis CKD patients. And one of the things that I liked a lot, and I am perfectly aware that this is not a KDIGO lecture, is that one of the reasons why we had such a debate with non-dialysis CKD PTH control is the word that we should wait to give active vitamin D compounds until severe secondary hyperparathyroidism was present, and you now changed it to significantly active PTH. Could you please tell us a little bit what is this big difference and how we may go for this significantly active PTH control?
Well, it's a terribly difficult definition, but what I would summarize here from my point of view is, first of all, take a look whether bone disease may be present. So look at alkaline phosphatase and bone-specific alkaline phosphatase levels. If they are relatively in the highest normal range or even above the normal range, this means that the PTH is probably active at the bone level, and we should do something about it. Also a situation where the other situation are the trends. They are, of course, also described in the KDIGO update and guidelines. So a rising PTH is much more important than the actual numbers that we do at a cross-sectional survey. So once we see that the PTH rises, this hormone needs a lot more attention, and we should probably make the controls more frequent. And when we see a continuous rise, then this diffuse hyperplasia is probably in the process to switch to nodular hyperplasia, and then we should act. And this is the absolute level is much less important there. And the third point is, if we have a situation with rising PTH, and this is said in the 4.2.1, and we have significant hypocalcemia, we certainly may need some degree of reasonable vitamin D treatment, including the active vitamin D treatment, because this is probably one of the strongest stimuli for PTH derangements. And this is what I understand with this activity of the disease.
Well, tendencies is a very important word in the KDIGO guidelines, and this concept of rising PTH is extremely important, and we think that we all agree on that. Don't we, Sandro?
Yes, I agree, and I would underline that even though we do not have a specific value of PTH as a target, I think that clinically we can consider a good PTH value the one that is easily suppressible with therapy. And I think that this emerged somehow in one of the papers that will be shown by Markus in his brilliant presentation. My question is that there are suggestions that in the early phases of CKD, at variance with me thinking until recently, due to the change in serum levels of sclerostin, there may be a reduction in bone turnover in the very early phases of CKD. And just only when PTH values increase more significantly, we can observe the increment of turnover typical of hyperparathyroidism. So my question is that if we start inhibitive therapies of PTH early in the course of CKD, are we inducing ABD? And are we underlining that early ABD without passing through secondary hyperparathyroidism is better than ABD developing, let's say, after parathyroidectomy? So not all ABD are equal. Do you have an idea about this?
Yeah, that's a good question. I think that we have some evidence from early but small bone biopsy studies that indeed there is this kind of PTH resistance, and that a higher PTH level is needed in order to have a relatively normal bone turnover in early or moderate CKD. I think Rosa probably knows more about this than I do, but I think this is pretty much true, but not supported by huge amounts of prospective data. So we are a bit in trouble here. And the second thing is what we always have to consider, how well Japanese CKD patients are doing with very low PTH levels. This is probably a racial difference when we look at European or even North American or African American populations. I think there is really a difference, but still we have to consider that no treatment is probably also not a good one. So the important question is the right time point. I think that even if we induce adynamic bone disease very early on, we might not run into the huge problems because there is no hyperphosphatemia yet, and usually also no hypercalcemia supporting calcification issues. But what we have to be aware, if we do it with active vitamin D, we might prematurely create a scenario where this happens. In addition to an oversuppression of the bone and taking the bone out of the business to buffer the calcium and phosphate loads. And I think this is indeed why I believe the KDIGO update is no nonsense, but a good warning sign. And it doesn't say that we do not have to use, we must not use active vitamin D, but it makes a bit clearer that we have to think before we treat.
So let me ask you a question. If you have the opportunity to see the rise in PTH, I think this is the most important point, to follow PTH and specifically know when it is rising. So what would be the suggestion that all of you would give in terms of what would be the frequency of measuring PTH in these patients?
Who should start? So if I start, I would, for example, see patients in CKD-3B maybe only half a year, every half, so after 6 months. And if I see that there is some movement, I would either convince the people to come every 3 months. In stage 4, they come every 3 months. I would try to convince them to come back after 4 to 6 weeks. So I would just increase the individual frequency, or ask the general physician, a practitioner who is usually guiding the patient, if he could make a blood analysis for PTH after this time and just send it to me for my recommendation or suggestion. So this is my immediate reaction I would have. And I would like to see at least 2 or 3 levels in a steady rise before I would make a treatment decision.
I completely agree. Actually, this is what we say in the Spanish guidelines of adaptation of the KDIGO, because this is the best way to see the trends, and telling the nephrologists that they shouldn't react to any little change of PTH, because there is also some variability in between measurements, of course.
Yeah.
Yes. I recommend to check PTH every 3 or 4 months according to the stage of CKD. The higher the stage, the worse the stage of CKD, the more frequently I check for PTH. Obviously, the trend is very, very relevant, because unless you do not have low levels of calcium, it is rare to see abrupt rising of PTH.
And what about the measurement of 25-hydroxy? This is a little bit more difficult to think of, because there may be a lot of influence of the sunlight. So what do you usually do in your clinical practice? It is not cheap either as a measurement. What can you comment on that?
I think Markus first.
Okay, can you briefly repeat? I was irritated about
instead of PTH levels, what is your recommendation about the measurement of 25-hydroxy? Which
okay.
is
Yeah, that's I always take it at the baseline, and usually after that I only look at it once a year, because I already have an idea about the situation of the individual patient, and the estimate how much to give, 1,000 a day, 2,000 per day, 20,000 per week, or something like that, is pretty clear. And I just make a check at baseline, and then fire and forget is possibly even the right description.
But I check basally 25D, but if there are difficulties, there may be some clinical points to consider the patient at increased risk of vitamin D deficiency, and that could be sufficient to decide to start therapy.
Don't any of you have into account summer or winter?
In dialysis patients or dialysis, we are not talking about dialysis, non-dialysis patients. No, not really, because people don't go out into the sun so much, and they use sunscreen. I only use it in people who are really a lot of at free air, also have gardening or doing gardening activities in the summer quite frequently. Otherwise, I usually keep it pretty straight.
Well, I think we need to interpret the value according to the season of the year you check the levels. Any season is useful, and you need to judge the value according to the season.
So we have some questions from the audience, and I was told to send them to you. So there is a question that Pablo Ureña. Hi, Pablo. He is asking if you have any concern about reaching such high 25 vitamin D levels and the occurrence of vascular calcification. And his point is that aortic valve calcification has been seen with levels around 22 nanograms per ml. Markus?
Yeah, I'm not sure. This is something we need to find out. I would, my warning sign is an overtreatment of calcium levels. So maybe even just above the median of calcium levels. Definitely hypercalcemia would be for me, and corresponding hyperphosphatemia an indicator. I'm not sure whether active vitamin D may leave already, or even inactive at higher levels, any footprint at the vascular tree by itself. I would I'm still a believer that this is kind of driven by the calcium phosphorus product in a way, but of course I'm not sure. We need to observe this.
And we have a clinical case here just to make things more practical. From a colleague. It's from a female patient, 50 years old, an eGFR of 20, PTH 360 picograms per ml, serum calcium 9.5, and phosphate 5 milligrams per deciliter. And she told us that pericalcitol provoked hypercalcemia, and the 25 levels are around 20 nanograms per ml. And she asking also, would you prescribe phosphate binders in this patient? And what else would you do to manage her PTH?
Yeah, I would first of all probably really start with calcium-free phosphate binder, because that may have already some impact on the PTH level. I would be interested whether she was on PTH levels of above 300 already for 1 or 2 years, because then I would not see the immediate dynamics, and PTH of 300 with a GFR of 20 could still be a little bit adaptive, or not already massively maladaptive. Otherwise, I would definitely seek for increasing the 25 OHD levels from 20, maybe double it at least with D3 prescription. And whether this might be an ideal patient for ERC, this remains to be observed.
Okay, so do you agree that phosphate binders and phosphate restrictions should be used when you have a phosphate level higher than something, or based on PTH, or based on fractional description of phosphate? What would be your thought?
Yeah, I would stick to the guideline update I was chairing 4 years ago, because I would only treat phosphate if there is hyperphosphatemia, at least at 2 consecutive situations. I would not give a phosphate binder just of when once the phosphate is elevated above the normal range. So, but if there is a trend and levels above 5 millimoles per liter, and maybe with a further increase the next time, I would start a phosphate binder. And if the calcium at the same time shows a degree of low calcium and hypocalcemia, I would, at first instance, consider also a calcium-based binder. So it just depends on the calcium level we are seeing at that time.
And can I say, would you consider also to evaluate phosphaturia in order to have an idea of how much the diet is contributing to hyperphosphatemia?
I'm not doing it frequently. I'm doing it very occasionally when I really see or have the impression from the history of the patient who is has let's say high phosphate levels, but is telling me that he's not eating any phosphate. So if there is a disconnect between the history and the lab values, I consider that. But I'm not doing it very frequently because mostly the history fits to the levels, the dietary history, and then I just think that there is a problem.
Markus, are you aware of any prospective study in pre-dialysis, in non-dialysis CKD patients using a comparison between different forms of vitamin D? Let's say extended release calcifediol versus paricalcitol or something like that?
I believe there is a study underway that is a relatively small study that looks at exactly this, but only on biochemical parameters. D3, ERC, pericalcitol or calcitriol, I don't remember very well, but I think there is a small study underway in order to have a look whether, for example, D3 is in high doses maybe close to the effects of ERC. But this study has been started quite some time ago, and I would have expected some results by now, but I'm not sure.
And are there any news on any vitamin D and heart outcomes in non-dialysis CKD patients?
Not that I'm aware of.
I think we need to have more data. We are still dealing with few clinical studies. It's a shame.
Okay. Do we have other questions from
Yes,
the
yes, there are.
Yeah, this is a question that it is necessary to perform bone densitometry as well as carotid internal thickness by Doppler sonography to fully access the CKD-MBD.
Difficult. I think also, as it is written in the guidelines, if the physician in charge thinks that this information would lead to differential treatment decisions, yes, one should perform them. I mean, for example, elderly lady with a high risk of osteoporosis profile anyway, with CKD stage 4, a low T-score predicts fracture risk. And this is similar to the normal population and would probably lead to try to address this with treatment. The carotid artery ultrasound is more, I think, a screening tool for classical atherosclerosis, maybe not so much validated for calcification, but could give a clue for general cardiovascular disease. And yes, if I have a strong suspicion or patients with a high lipid or with a unhealthy lipid profile, I would probably do it. But it's possibly not necessary to perform that in any patient at any stage of CKD. I would do it very individually.
Okay, so let's hypothesize that this patient has a considerably high PTH, so this patient of 360, and at the same time has a low bone mineral density. Would you be more aggressive in treating PTH when you see osteopenia or osteoporosis that was seen by densitometry?
I probably would, but I would also then definitely take a look at bone alkaline phosphatase levels, because if this patient would have completely normal or even low AP or BAP levels, I would be again a little bit hesitant about the right treatment. I would think maybe I need a bisphosphonate, maybe I need in the GFR20, that's not a good thing probably anymore. Denosumab maybe, I don't know, it's a difficult situation. Or even better, perform a bone biopsy then.
Okay.
Well, that's good point. Perform bone biopsies.
We should go for them more often now, definitely, with the new needles and new tools. Yeah.
Well, I am a little suspicious to talk about bone biopsies because we are very fan of this procedure. But I think that in the near future, if we want to recommendate or do not prescribe drugs such as biphosphonate, teriparatide, or even denosumab, we need to have bone biopsy data. We need to have the safety data to be able to prescribe or not to our patients. I think we need safety and also efficacy data for non-dialysis CKD patient. This is very important.
Fully agree.
But on the other hand, bone is not the only target of PTH. We haven't talked about the PTH as an uremic toxin. Do we know all the levels of PTH that can be toxic for the heart or another tissue?
No, we don't. I'm not aware of any human clinical study that has this answer.
No, of course not. And again, maybe this is another reason not to tell people to wait until severe secondary hyperparathyroidism is present to treat PTH, and you choose either what you think is best: extended release calcifediol, active forms of vitamin D, and we definitely need those studies. But probably not to wait until severe secondary hyperparathyroidism is present to think about these new drugs. Wouldn't you agree, Markus, Sandro?
Okay, I agree perfectly. Do not wait too much for very high PTH levels, because then you can have a non-suppressible PTH.
Right.
So do you have any questions or remarks that you want to make? Because we are very close to the end of the session, and I want to, if you want to make any comments.
Well,
okay.
There could be so many, but I think that we said something specific, and I think that Markus should make some specific conclusion on this, because
yeah.
Well, I tried to summarize in my last slide what I think, and in the essence, we probably have to make a lot of individualized treatment decisions. There are no clear-cut numbers. We are a bit different here from the cardiologists. We have a more complex scenario. I think the interdependency of at least 3 to even 6 parameters is of importance, and we need to go step by step from CKD stage to dialysis, back to transplantation. So there is a lot to consider when making these decisions. And the important thing for SHPT in pre-dialysis patients is probably to stop the dynamics, to halt the progression, and doing this at the right time point with a moderate effort that has no side effects. And this is difficult enough, but I think we have a few tools that help us doing the right thing. So that may be as a conclusion.
very good conclusion to me.
Yeah, very good. So I would like to thank you, Markus, our speaker, and both panelists for helping us. I think the discussion was very good and it was provocative. And the only thing that we should keep in mind that do not forget of measuring PTH and seeing the entire movie instead of a picture. So I will finish with this message that the next working group seminar titled Obesity in the Renal Transplant Candidate is scheduled on November 16th, and it is organized by the Descartes Working Group. So I thank you so much for your participation. Thank you.
Bye-bye. Good evening.
Bye-bye, everyone.